Welcome everyone. Before we start, anyone has any question? And regarding this topic, which I am planning to discuss today, has anyone got any idea what is it? Never events.
Yes, sir.
What is that?
First, okay. So these are the things that we should never do.
Like
Some of the
we should
the
not.
rules.
We should never. We should never attend the classes when Dr. Zishan is sending the link, because everyone in the group is busy in ABCD MCQs answering. Is it that never events?
Can be.
Anyways, I'm just kidding. Yes, please.
So when I saw these topics, like these points, I wanted to ask why we are discussing them, because never to to avoid them. But in case if any of this happen, is there an antidote? Is like we can manage it?
Okay. Any other thoughts from anyone else? How many of you have heard this topic before?
Sir, I have done the trainings that
Okay.
are mandatory for these topics. Only
Uh,
that.
Actually, what is the first never event? First never event is actually, for example, if the patient is coming and patient is not for that surgery. Okay. So this is the first never event, that you are bringing a wrong patient for the wrong surgery. You are doing wrong sided surgery. You are doing wrong sided block. Okay. For that, actually, this is the thing which used to prevent it. Not every part of the world they are doing it. Okay. Especially in low socioeconomic setup, we are not doing it. But actually, this is the WHO surgical safety checklist. Okay. And there are some concepts about it. I will just try to tell about it. Okay. So just have a look at it. And actually, there is a terminology of briefing, debriefing. Have anyone heard about it? Team briefing, debriefing.
It's the protocol that is being observed before the start of the surgery. Like there are some checklists that we have to do. Normally the staff does this, including
Yes.
the also the residents and the surgeons and the anesthesiologists.
Yes, actually there is called as team briefing. Okay. In the team briefing, the surgeons, the nursing staff, the anesthetists, they are all having a discussion about what is the procedure, what are what are the limitations, what is their plan, what equipment they need. Okay. So this is the team briefing. Okay. And then there is a sign in, check in. Sorry, it is the first thing. Sign in, time out, and sign out. Okay. So that's what they are doing it. So check-in is the patient when the patient is received outside. Okay. And they are checking. Actually, check-in and sign-in may be done together. Okay. So that they check the patient identity, site. There is a site marking being done. If it is not applicable, so they will write site marking not applicable. Okay. Then they will write procedure, consent. Consent issues are very important. Okay. We have to, whatever we are doing, there should be a consent, because if someone of us at the moment is from like preparing for some international exams, so this is a common topic being asked related to concerns related to consent. Okay. So consent, if it is not properly done, even if you want to take arterial line, central line, of course in emergency if you need it, you can do it. But actually you have to take consent of any regional anesthesia, any block, arterial line, central line, even Foley's catheter, you cannot put without the consent of the patient. So for everything we are taking consent. Site mark not applicable. Okay, anesthesia safety checklist, like all the circuit is checked, all the airway equipment is checked, resuscitative medication prepared. Okay, and the monitoring which is needed is there, suction is there. So like part of the anesthesia checklist, everything, all the safety things, suctioning, emergency medications, as I told you, ambu bag. Even if you have 1,100,000 of cylinders, you should have the ambu bag and emergency cylinder attached to the machine. We will discuss sometime in detail anesthesia machine checklist, inshallah. But this is what we are doing. Then the patient, any allergy, okay, difficult airway aspiration risk, and equipment which they need is there. Okay, then about blood, do they need blood, or they are expecting major blood loss. Okay, so at the same time they are also thinking that, for example, if there is a special patient age group or anything special they need, so they will be discussing out. Okay, timeout is before incision. Okay, usually they confirm the things which they want to confirm. All team members have introduced themselves by name and their role, so that everyone is knowing about each other. Okay, so surgeon, anesthetist, professional, nurse verbally confirm patient side procedure. Okay, the patient in the hospitals where they are doing it, actually it's a second nature. But like in Pakistan, I never saw it. When I came to Saudi Arabia, in every hospital almost it is being done before they start. Okay, what are the critical or unexpected steps, operative duration, anticipated blood loss. Okay, the purpose of all this is to avoid any intraoperative events. Okay, like for example, patient was anemic, they did not arrange the blood. Okay, patient, the surgeon needed some specific instrument, and in between they come to know they don't have. Okay, suddenly if something goes wrong, it's something else. But pre-operatively they have to check all the sutures, all the equipment, or everything related to it. They are supposed to check it out. Okay, antibiotic prophylaxis. Regarding antibiotic prophylaxis, usually it is to be given 60 to 90 minutes before the incision, so that the blood levels are being achieved. Okay, if any point of care testing is required, any imaging intensifier is required. Okay, so this after the surgery, they ask the surgeon, what did you do, sponge count, equipment, instrument. Okay, needle count, everything is being done, labeled. Okay, and then they will ask where the patient will be going. Okay, whether the patient is going to ICU or HDU, or a patient will be having the normal course of the normal care, standard 1 care or standard 2 care, which we are providing. Okay, so this is the concept of WHO surgical safety checklist. And to avoid, because with this you can avoid any wrong side surgery, wrong patient, and you will avoid any possible complication in the procedure. Okay, so now I will just try to tell few of the complication which you can have if you have not done it. Okay, like for example, you the patient had some allergy and you couldn't pick it, known allergy which was missed. Okay, patient had some medical disease and it was not seen in the pre-operative checklist, and you face some problem. Then for example, wrong blood. Okay, does anyone know how to check the blood?
Yes, sir.
Yes, how to do it?
So we will take the blood sample from the unit of blood and from the patient.
No,
Then
the
first
blood.
we will
now the blood is coming from the blood bank to now you.
From the transfusion. Yeah, we are provided with some card. We have to put in the saline on all the four. There are four
No,
boxes
no,
each, 4 circles. We have to put in the saline,
no, 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 no,
and we have to match with the patient's blood and with the
no.
transfusion bank.
Let Dr. Yasin
This is
just
how
try to.
I.
No, no, just a second. Just try to answer, Yasin. Yes.
Assalamu alaikum.
Very good.
We have to cross-check the hospital case number with the blood bank details that was given
Hospital
along with
MR number,
the
medical record number.
MR
Okay.
number. Then the blood group, the same blood group is not. And then we have
Expiry
to
date.
check the expiry date.
Yes.
We have to check the expiry date and
Patient, actually patient
patient
ID,
name and details.
ID band.
Yes.
Okay, because sometimes the patient ID band, now the patient is draped already. Okay, and because you know what,
Yes.
what I wanted to tell you, that the paper with which the blood is coming, and the blood itself it's not the correct way, because paper and blood will be the same, for example, but the patient where it is giving is not the correct one. You understand that they bring the
Okay.
patient, they bring the blood, there is a card with the with that blood, but because of course they are same. Okay, but you did not, because this is usually about the donor. Okay, and usually recipient information is not clearly mentioned, or for example, even if it is mentioned, you still have to reconfirm with the patient ID band, with the patient file, and preferably with the patient's anesthesia sheet if you have. Okay, you will reconfirm again that the blood which has come is belonging to the patient you are dealing with, because I have seen even at least 2 times in last 2 years that the wrong blood came to our room, because in big hospitals there are maybe 20 rooms, the porter is bringing the blood and it has reached to the other room. Okay, now for example, if someone does not confirm the identity with the of the patient, the card is the same as carried by the in the that box in which there is ice, the card is inside, you open it and you took the blood and you match it, you said yes, very good, but actually you are heading toward a disaster because you did not confirm the patient ID. Okay, you understand now, Zenera? You understand?
Yes, sir. I misunderstood the question. Yes,
Yes.
perfectly.
And actually, it is actually at least checked by 2 people, not 1 person. One of them usually is nurse plus doctor. Okay. And then they, what other precaution they have to do? They have to take the pre-transfusion vitals. Okay. And then they observe 15 to 30 to 45 to 1 hour the readings. Okay, because minor reactions can occur, and if blood transfusion, some minor, we will just try to cover this topic simultaneously, that what will be the signs of blood transfusion, early signs of blood transfusion reaction. Maybe we discussed before, it may be very masked during operation, during intraoperative, so maybe even intraoperative increased airway pressures, peak inspiratory pressure is increasing as a early sign. Okay, because if there will be hemolytic reaction, there may be even hematuria or hemodynamic collapse. Okay, because rash or fever or tachycardia may be masked during the anesthesia. Okay, so this is, you should be knowing when you are starting it, and when the blood finish, they have to countersign it by the doctor post transfusion reactions. Okay, then there are like certain things which you have to warm the blood, attach with the warmer, blood warmer. Okay, and initially you will start slowly, and then other protocol. So it is one of the never event that you give the wrong blood. Okay, then another wrong event is that you put it on the wrong side, like for anesthetist, you wrong-sided block. I will not hesitate Yes. Can you hear me now? Actually, I think, disconnected. Can you hear me now?
Yes.
Yes. So wrong-sided block. So I will not hesitate to tell you that one time in my career, I have given wrong-sided brachial plexus block, because usually they used to do it always on left side. And in that patient, they had some issue and they wanted to do it on the right side. Okay. So I gave the block on the wrong side without checking. So that was the error done, combined by me and the nurse. Yes, Zunaira?
Sir, I didn't understood how like they were always giving on the right side.
No. They were their routine in that hospital. I'm just sharing with you. And that hospital, they used to do the fistula. It was AV fistula. They were doing always in the left side. But and that patient, they wanted to do it on the right side. Okay. So that became the reason. I'm just sharing.
And sir, what were the consequences after that?
Nothing. Anesthetist is miskeen. He will have to face consequences anyways, even if he has not done a blunder. This was a blunder actually. But actually they had to cancel that day because can you give block on both sides? Brachial plexus block?
No.
Why?
Because of the it may involve phrenic nerve.
Phrenic nerve. So if you block both sided phrenic nerve, then okay. So never do it. So wrong sided block. Okay. Then something related to drugs. Okay. What may be the drug errors which can occur? Wrong drug. Okay. Wrong site. Wrong concentration. Okay. Wrong site means intramuscular drug given IV. Okay. Things like that. Wrong concentration. Wrong dose. What is difference between concentration and dose? Any junior, please. Yes, Shumail.
Please repeat the question.
What is difference between concentration and dose? Like there is, I'm saying the concentration is.
So I think the difference in the dose is per kg, sir.
Yes,
the dose of the drug used per kg.
Dose, like for example, if you have to make 100 milligram, one that you have to make it in 20 cc, for example, and the same 100 milligram you prepared in 5 ml. Okay, so it will be concentrated and it can cause some intravascular problems. Okay, you understand? The example.
Yes, concentration is in percentage, not usually.
Yes,
yes, sir.
Of course in percentage. Okay. So that is, so you can have in drug errors, you can inject a drug to be given IV in epidural. It's a common mistake being done. Spinal. Okay. People have injected almost all over the world. If you see the case reports, almost everything is being injected in the CSF by mistake.
Yes, sir, I did once.
Okay. So I have given ketamine. Sorry, in mistake of ketamine, I had given suxamethonium. Okay. So suddenly patient started twitching and then I came to know that what I have done. Okay. Yes, Zunaira?
So, sir, I want to ask also, like if someone is mentioning they gave some wrong drug, okay? So how they manage it?
It will be depending on the situation. Like if, for example, in place of suxamethonium, in place of ketamine, I gave suxamethonium, what I will do? I will immediately give some this hypnotic agent and I will intubate. There is nothing needed else. Nothing else is needed. Just imagine in awake patient, if you give suxamethonium. Why I'm telling my name? Because if any anesthetist in the world say or claim that he has never done a mistake, he is lying to you. Nobody came from the womb of mother, learned everything. Okay. Everyone is prone to do some mistake. Yes, Zunaira?
And what if we mistakenly give something that is not supposed to be in CSF? How
Nah,
to avoid that?
you can only pray. Nothing you can do. There is no way to avoid anything.
You cannot aspirate.
Can you aspirate? Will you aspirate
So,
all
so
CSF?
how can we place?
Okay. So you cannot do it. You can only pray. And for example, yes, you can be ready for something. You can give some. I'm just giving you a blunt idea that you may be giving some. For example, if you give any medication which can cause reaction, maybe you can think about dexamethasone, giving dexamethasone or any neurological support or any ready observing the patient in HDU. That's what you can do. Nothing else. Okay. Yes, Dr. Sadaf. Yeah, unfortunately, we cannot hear you. I'm sorry, we cannot hear you. I'm sorry, Sadaf, you can write the message in the chat. I will try to answer. Okay, so wrong route. Actually, I'm watching a lot of cricket, so I'm writing route. Joe Root, a cricketer. Okay, so it's not that route. It is that route. Okay, so wrong route, wrong concentration, wrong dose, and another in the route. The most critical mistake is to give intra-arterial. What will happen if you inject any medication intra-arterial?
Extreme pain.
Very good. What else?
Vasospasm.
And the damage to the, I don't know the right word. There is a damage to the walls of the arteries.
Okay. Anything else?
Yes, spasm. Vasospasm.
Actually, the answer should be that it will be depending on the medication you injected. Okay. Because some medication won't do anything. Okay. Like for example, if you injected lidocaine intraarterial, will it do anything?
Nothing.
Nothing. Okay. So like it depends on the medication you have injected. Then they give the example of this thiopentone. Okay. So in that there will be severe pain, vasospasm, okay, thrombosis. So anything will be occurring, can occur. So what will be the management?
Lidocaine.
Immediately lidocaine or
No. First of all,
I have heard
stop
like
the drug.
stop
First
the
of all,
drug.
stop the drug. Don't pull out the catheter or cannula.
Yes.
And just wash it with the normal saline. Give papaverine, lignocaine, and steel and ganglion block if it's in upper limb, or if it's in lower limb, then lumbar sympathetic block can be given.
Yes, that is the protocol. Okay, because the severe pain you need, you both of you have missed something. That would you like to give something for pain as well? Okay, if you are not able to control the pain, you have to give some analgesic, and otherwise. Okay, so of course this will not be effective too much, but when they are asking you the management, you have to tell analgesic as well, in addition to what you told, that you will keep the cannula inside, you will try to inject some saline, you will try to inject lidocaine, papaverine, and then stellate ganglion block. Okay, so another complication which is related to drug with IV, drug extravasation. Have you ever faced? The cannula was out, you are injecting medication, and now, for example, there was a surgery TIVA, and the drug was going out, and patient was wrapped. And now, when you see, actually, even the bestest hospital like King Faisal, we had this complication over there, that one of our anesthetists, he was doing a case, and the TIVA somehow some of the drug was going, but some of the medication was going in extravasated, and there was a swelling that, like, it was propofol, opioids, Okay. So what will you do? Like if you have a swollen limb, what will be the protocol? What will you do?
So I'll stop the drug and take a new IV line.
Yes, stop.
We
the
stop
IV
the drug.
Then
We give normal saline, sir. And then,
mm,
if the hand swell up, sir, we stop the drug and then we raise the hand.
very
So
good.
that
Raise the hand, raise
Yes,
the
sir.
limb. Okay. And you put a crepe bandage.
Okay.
Crepe bandage in the reverse direction of the flow. Okay. Like like from distal to proximal, you will put it in a way and elevate the limb. Okay. It will, but what about if you have given rocuronium or any muscle relaxant?
So we have to intubate, sir, as you said, sir.
No,
Sir,
the
We
patient,
have to.
patient will be intubated, but the problem will be that if you have rocuronium, the problem is not that much severe because you can give Sugammadex, but you have to monitor the patient in HDU in such cases. Okay, because there are always chances of recuriorization. Okay, because there will be residual and it can create problem. Yes, of course, the absorption will be slow and maybe it will not create a big problem, but still you have to anticipate and because this can, you can do the neuromuscular monitoring. Okay, so
Yes, sir.
this is the, so elevation, crepe bandage and monitoring. Okay, even for example, if you have given opioids, it can still cause respiratory depression. So any medication which will have extra metabolites, you have to take care, and the smart answer or smart thinking will be to observe the patient in HDU. Okay. Yes, Dr. Sadia.
Sir, will there be any role of tying a tourniquet
Tourniquet
in
will
case
do
of
what?
rocuronium?
No.
Like,
No, I don't
okay.
think so. Because you know what will do? What will it do?
If you release the tourniquet, then
edema?
again effect will come.
Again it will come. Okay, so actually you
Okay.
see, this is also one of the topic which is being discussed in the this FRCA mind map. I wish when I were a resident I had these things. Believe me, I must be flying at that time, and you people are so lucky to have these sources with you. Okay, so risk factor, elderly, fragile vein, neonates, venous thrombosis, vein thrombosis, obesity, detection difficult, IV line, already there is swollen. Okay, so you may be missing it, and especially if you have a small cannula and you are putting it under the pressure, so this will also one of the reason. Okay, so pumps can continue to infuse to perivascular tissues because syringe pumps, or if you are going with any infuser, it will keep on going, and even if the this one is you are giving it as part of anesthesia, you will not be able to pick it. Okay, like if you are giving inhalational agents as well, and you are using, this happens actually if you have a dedicated line through which you are giving some medication, and you have given the anesthesia by some other way, and now you are not able to pick it up, and when the surgery finish, you are giving ringer lactate, it can extravasate and it can create a big problem. Okay, so the medication may be anything, maybe only fluid or anything which can create problem. Okay, so this is just they have done about this intraarterial injection as well, pain on injection, this observe and dark, obese and dark skin pigmentation at risk, hypotensive patients, sedated patients, intraarterial drug injections. what will happen with arterial vasospasm, direct tissue destruction, arthritis, release of thromboxane, and drug precipitation. Okay, and recognition due to pain, pallor, cyanosis, hyperemia. Okay, anticoagulation with heparin or papaverine. This one, papaverine is vasodilator. Okay, may need to give heparin as well. Okay. Stop injection, aspirate via the cannula if possible, leave cannula in place, elevate limb, saline washout via incision around the extra visited site. Even they can do this. Liposuction. Interesting. Hyaluronidase. What will be the role of hyaluronidase, Usman?
Sir, it will increase the absorption.
Increase the absorption. Okay.
And
Yes.
regeneration.
Okay.
Basically, it is connective tissue destroyer. So it increases the absorption. It will not accumulate the drug there.
Okay, so I think you people understand the gravity of the topic. This was the original article from which I got this idea. Okay, never events are defined as serious, largely preventable patient safety incidents that should not occur if relevant preventive measures have been put in place. Okay, like if you check the blood, you check the site, you confirm the patient, you are following the WHO surgical safety checklist, then you will be able to avoid them, because still even after that you can have some problems. So maybe some new list has come, but I think this is to date the latest one. Maybe if someone know about something new, I'm not sure. Wrong site surgery, wrong implant. Yes, actually I was just trying to recall another incidents related to anesthesia is a retained throat pack. Okay, so what will be the problems if the throat pack is retained, or how to prevent this thing? Yes, anyone related to throat pack?
Sir, actually, when it's done, there is a checklist. When they are putting the pack in, they let the assistant know, the surgeon assistant, and they also check, counter check with the anesthesiologist. And when they about finish the surgery and they are taking out the packs, they like they check it again if they have taken it out, all the packs, like they number them.
No, this is related to surgical packs.
So you can, basically attach a ribbon with a throat pack, and the ribbon should be of
should
adequate
not be
length.
put all the way through. There should be the distal end should be attached to the angle of mouth. Okay, because this will prevent that you will not forget, because there are incidents that the throat pack was left at the place and it is being removed after the patient is having choking. Okay, in the post of recovery they are removing it, they forget it. Okay, so recently I just heard about a very serious incident that someone was giving spinal. It's a real-time incident, it's not written somewhere. The patient, they were giving spinal and they give local. The patient has vasovagal. Okay, so what will you do if you have vasovagal, sudden patient becoming sort of collapsing, bradycardia? What will you do immediately?
Sir, we will elevate the legs.
You will make the patient supine first. Okay.
Yes, sir, definitely.
Of course, you are giving a block in sitting position. So supine and then elevate as you told. So what happened? A consultant by mistake, when the patient had vasovagal, he was giving local, and in hurry, can you believe this? He did not remove the needle, 3cc syringe which he was using. Okay, so the needle with the syringe remained in the patient's back, and they shifted the patient. Nobody came to know. And later on, the patient had pain, and the patient was complaining of back pain, and the nurse examined the area and she removed the needle with the syringe. So it's a nightmare. It's a nightmare. And it happened to a very senior consultant anesthetist in Saudi Arabia, actually. You see? So that's why all anesthetists should be very near to God and always doing tawbah, saying sorry to Allah for anything wrong. Okay, because you can face so many things. Another which I never even, it is actually a complication, is broken needle. Okay, so needle can broke inside, especially if you are using 27 gauge spinal needle, which is very thin. Okay, there was an incidence of a cannula tip being broken. Okay, cannula tip being broken and the part remain inside. So then it can create a lot of problem. Okay, so foreign body is this one, throat pack. Always whenever we are putting the throat pack, you will label that throat pack in, you will keep the outer edge attached to the side of the lip, and you will the nurse will note down on the chart, there is usually a whiteboard in hospitals where they will just note it down. Okay, and you will remove it later on after doing suctioning, and then you will again announce that throat pack out. Okay, so then wrongly prepared high risk injectable medication. Okay, that you did not prepare the medication nicely, you did not label. There is a common mistake which people do if they are diluting, double dilution. For example, I will give you example of 10 milligram of phenylephrine, which everyone is using. So always try to dilute it in 100 ml bag or even 500 ml bag as you want. But if you are taking in 10, so it will be 10 in 10 ml. So it will be like 1 milligram per ml. So it is 1000 microgram per ml. And by mistake, and then you take 1 cc, 1 ml from it and dilute again in 10 ml. So it is 100 microgram per ml. Okay. So what happened that by mistake you labeled it wrong. So actually you are giving 1000 mics or 1 milligram. So patient, what will happen to the patient? Patient will have sudden bradycardia and even arrest. Okay. So, and blood pressure will also go shoot up. So this is another thing. Another thing, yes, I recall. I'm just trying recalling the things, and I'm telling you, there is a standard syringe labeling system. Have anyone know? Do anyone knows about it? There is specific color coding for medications. Okay, like muscle relaxants, they are usually red. Induction agents,
yes.
usually yellow. Okay. The reversal agents usually green, things like that. It's not a perfect one, but like there are
Opioids blue.
I'm sorry,
Opioids blue.
opioids blue. Okay, opioids are blue. So this is how they manage it. There is a specific syringe labeling. Another way to avoid errors in syringe labeling is that the hospitals, they can, or operation theater anesthesia department, they can have a specific protocol for 20 cc syringe, for 10 cc syringe, for 5 cc syringe. Okay, for 3 cc syringe for specific drugs. Okay, specific drugs, so that you are not doing any error. And then specific concentrations. Okay, to avoid drug errors, because I again repeat, these are the most common things which no anesthetist in the world can claim that I have never done a mistake. If he says that I have never done a mistake, unfortunately, most probably he is lying to you, just to impress. Okay. Then potassium with reference to, like in Pakistan, we have potassium chloride and dextrose water. So I think whosoever has worked in a government hospital in Pakistan might have seen this thing. That unfortunately,
Sir, yes, I have done it. I have given KCL directly.
yes. So you see, that's why usually whenever we are making this the syringes, there should be actually there should be two people, better to have two people to confirm, okay, to confirm the injection, and so that you avoid these things. Okay, so dextrose water versus KCl. Okay, usually there is in the good hospital, they have high alert label attached to the vials or ampules. Okay, they attach a high alert red colored label that it is high alert medication. So you don't yes, there is another concept of look alike, sound alike. Does anyone know about it?
Yes, sir, like transamine and tritium.
Yeah, it is called as LASA, right? Look. So this is also never event that you give a look like sound alike medication. And a very common, like common people don't pick it, is one of the example is where has it gone? Yes, this one tramadol and toradol. Okay, tramadol is this one opioid.
NSAIDs. Opioid, sorry.
Tramadol is opioid and toradol is ketorolac, which is NSAID. Okay, so this is like some of the never events which is related to anesthesia. Other some administrative issues like they have given, okay, that suicide and escape and fall. Yes, fall of the patient is also a never event. Okay, and especially I will suggest you something, that whenever you are giving spinal in a sitting position, always keep another person who is holding the patient. Never ever try to do it without a second person who is not behind, in front, because sometimes your assistant is behind you or with you and there is no one in front of the patient, so patient can fall down very easily. Okay, so because some centers they are doing with the patient hanging the feet outside. Okay, especially people who are doing epidural, sometimes they feel it comfortable, they sit on the table and let the patient hang the legs on the other side. So to avoid this never event, you have to keep to hold the patient nicely. Okay, otherwise they have labeled it, you see, wrong implant, wrong site surgery, retained foreign object, wrongly prepared high risk injectable medication, maladministration of potassium containing fluid, and they have just written overdosage is also never event. Like, do you know what is opioid nave? Usman, you will know it, so I will try to ask to someone else. What is opioid nave? Anyone knows about it? What is opioid nave? Anyone, please? Zunaira?
Sir, opioid knife, these are the old patients?
No.
No, I
The
don't have
patient has never received opioids before. Okay. So their requirement may be less than a person who has received opioids before. Okay. So then actually in virtual meaning, you can consider all complications as never events. Okay. Any embolism occur, any tube dislodgement occur, you put an endotracheal tube in esophagus, you put a endotracheal tube in bronchus, you took you were trying to take a block, you put it in the artery, you rupture the artery, it is also never event. Then another important never event, when you are putting CVP, sometimes the CVP from subclavian, instead of going down, subclavian can go up. going towards the brain. You understand that you are putting subclavian. So instead of going down, because when you are taking internal jugular, your direction is toward heart. Okay, but subclavian, it can go in the other direction. So there are incidents in which the CVP will be going up. Okay, and
how to avoid that, sir?
You will just confirm it. There is no way to, because if
Don't pull CVP too much.
Don't pull CVP. Actually, of course, usually that's why you see whenever we are putting the guide wire, sometimes people, when they see that there are arrhythmias, it's a sort of, it's not a very good way. But actually, when you are putting CVP and you see some PVCs, it means you are at the right place. Okay. And then you have to confirm it radiologically. You can do X-ray, you can do ultrasound just to confirm the positioning. Okay. So I hope you enjoyed this atypical topic. Any questions?
Sir, if you can explain again the difference between the concentration and the dose.
Yes.
What I understood is like concentration is the one that we dilute and dose is the dose that we have to give per kilograms. No?
Because if you are giving a drug very concentrated, it can have some vascular effect. Okay. The one of the example is thiopentone. Usually it is advisable, because most of you have not used thiopentone. Usually it is advisable to make it 2.5%. But if you make it 5%, it will be concentrated and it can cause pain. It can cause problems. So whenever,
yes, very caustic.
Yes. So it's a basic drug. So it is causing pain. Okay. So then another thing is that, for example, because as much concentrated medication you are giving low volumes. Okay. So if, for example, by mistake you give a big bolus, it will have very pronounced effect, which can be very dangerous in some scenarios. Okay.
Sir,
yes,
you forgot to discuss the size of syringe also. Sometimes 5 cc syringe
yes,
or 10
yes.
cc.
What is like a question that what will be the effect if you are using a 20 cc syringe versus a 3 cc syringe?
The flow. It's the Poiseuille's equation law.
No, but the word is not flow.
Yes.
Word is not flow. Yes, Usman, would you like to correct it?
So I think
It's force per
flow per
unit.
time. Yes, for flow per time.
No. Actually, when you are using
Okay.
20 cc
Okay,
syringe,
I think you are trying to say about the use of force. Like in small syringe, you have to give more force.
no, small
Okay.
syringe is you have to give less force.
Oh
It's
yes.
the
Okay.
radius.
Yes.
It's a radius. If you have a smaller no, it's force per unit area. The area where you are putting the pressure. If you have a bigger syringe, you need to have more pressure. Okay. So
Yes, sir. In epidural. Yes, especially in epidural.
not only in epidural, in any route. If you are giving a nerve block, okay, and you are using 20 cc, ideally, because actually all of us use 20 cc. Am I right? Majority of people are like lazy to use 10 cc. But if you ask me, we should not use 20 cc syringe for giving nerve blocks. Why? Because we are giving under more pressure. Okay. If you are using 10 cc, the pressure will be less, and you will be identifying, because if already you need to give more pressure to give the same flow. Okay. So then it will be a problem. Similarly,
It will displace the nerve.
it will no, you can inject intraneural. Okay. You will not maybe or not able to identify whether you are intraneural or whether this is because of the syringe. If you are using smaller syringe, it will tell you immediately that whether if you are intraneural. So it is better to use a smaller, especially in pediatrics. In pediatrics, if you are giving, even if, for example, in 20 cc syringe, if you are giving some bubbles, and there is not pediatric, even neonate, for example, okay? So if the patient has some residual fetal circulation,
PDA, yes.
any residual fetal circulation, you can have paradoxical
Air embolism.
Okay. Usually it will not be occurring. It will be only if the shunt is right to left. Only then it will occur. Okay. But actually, for example, 1 ml per kg. So if the baby is 2 kg, or even you can have neonates even less than 2 kg, premature. So even if you inject a smaller amount, which may not be harming in any other patient, it will be significant. Okay. So that's why you need to use, thanks Dr. Humera for reminding. Okay. You see, if you will point me out for something nice, I will be very happy. Okay. Thanks that today you pointed out something valid. Okay.
And sir, how much air should we avoid in order to avoid the embolism? It's 8 mils or it's 20?
Don't try to inject any ml. Okay. Yes, Dr. Sadia.
Sir, I have read it like 25 ml is the dangerous.
No.
Danger zone for causing air
it's an ml
embolism.
per kg. It's an ml per kg because for a child it's less, and for an adult it's more, and then it also depends that the patient is having any shunt, VSD, SD or PDA. So then the dose might be changed.
Yes, and you see now this person is messaging me, Rafat, and he's not attending the class. Anyways, I reply to everyone. So I will just show you this thing. This message I prepared, and before finish, I will just give you a look. Maybe majority people have not seen this message before. So a logical approach to anesthesia complication, challenges or critical incident. And many people, many new residents, they ask how we should proceed with our training, or how we should proceed with our learning. So believe me that if you are able to understand the problems which you face in the anesthesia OR to start with, how to deal with them, like blood pressure going up, going down, heart rate going up, going down, rhythms problem, temperature, hypothermia or hyperthermia, and then whatever the causes of tachypnea, bradypnea, respiratory rhythm. This in case of this awake patient, for example. Okay. And if cardiovascular collapse, cardiorespiratory collapse occur together, yeah, that's why I've written as combo deals, pulmonary embolism or tension pneumothorax. Okay. And cardiac tamponade will also be causing here in the blood pressure, because there will be reason for it. And then problems related to conscious level. Okay. Then pressures in the body cavities or chambers or vessels related to tourniquet, clamping, abdominal compartment syndrome, limb compartment syndrome, cardiac tamponade. Okay. Low or high cardiac filling pressures. Any word which we don't understand, please ask. Okay. In tourniquet, there is a problem. If you are clamping or unclamping a vessel, there will be a problem. Abdominal compartment syndrome, if you are giving too much pressure inside the abdomen, pressure is increasing because of any reason, because of any pathology, because of anything, then it will cause, because all systems will be affected. It is in the abdomen, but it will be causing decrease in cardiac output, decrease in ventilation. Okay. So that will be, then maybe renal perfusion may decrease. So there may be renal failure. So things like that. Okay. So acute organ failures like respiratory failure, cardiac failure, liver failure, renal failure. We are talking about acute organ failures, not chronic. So acute respiratory failure, acute cardiac failure, acute liver failure, acute renal failure. We face this thing usually if you are not giving adequate fluid. It's sort of renal failure because you are denying the patient from the fluid and the kidneys are not producing urine. So actually it's a sort of in not true sense renal failure, but actually you are heading the patients toward renal failure. Okay, so things like that. So just have a look on if you can try to understand this concept of understanding, because this will be beyond the normal chapters of the book. But if you understand like that, you will have a very good concept. Okay, so any questions before we finish? Anyone? I hope you people understand, because today I was in a lighter mode, and because day after tomorrow there is Eid, so maybe we will not have any discussion tomorrow or day after tomorrow. So I just wanted to say all of you Eid Mubarak. And any questions, please? There are some people who have come for the first time. Ahmed Zunnur, I think he is new. Sadaf Awan, she is new. Any question, please don't hesitate. And the good thing is that I cannot punch you through my laptop. So don't feel free. You can run away very easily. Okay, no questions.
Sir, I have a question. Rather, it's a discussion slightly. If the never events come, then how we should explain to the patient, and we have to write it on the paper, and then medical legal issues and aspects. Kindly, if you can touch it.
Actually, of course, you have to accept the mistake. Okay, and they have all the right to sue you in any court of law, because if you do something without checking it, I'm not sure about what will be the exact answer to this question, but you have to counsel, you have to try, because a never event actually are not, for example, if you are telling anything, like for example, if you are counseling the patient for epidural and you tell the patient that there may be inadequate block or partial block, or you can have PDPH, there are so much incidence, so this will not be considered as never event. Okay, especially for example, during intubation you break the tooth, so so whenever we are taking anesthesia consent, we have to tell that we have to pass a tube through your mouth, and during the intubation you can have some problem. Yes, if you are anticipating, you will tell, and if you are not anticipating, then you have to counsel it. That's it. I hope I answer your question in a little bit way. Yes, Usman.
Right.
Yes, Arif.
Sir, if there is a broken needle or
Unfortunately,
the protocol procedure.
Your sound is not coming. Perfusion as well.
If there is a,
I'm sorry, I did not see the messages. I asked you to send the message and I did not see. I apologize for that. If you use injury instead of failure. Yes. You are perfect. You are absolutely right. It's injury, and never as a topic. Wrong arm for the block. What else? The messages. I'm just trying to see. Some of the side effects of different drugs wrongly given in CSF. Yes, Sadaf, you are still here, I think. The thing is that it will be depending. Usually it will be in the form of meningitis, sign of meningeal irritation. It can cause meningitis usually. Okay, it can, like for example, before we used to give, they used to give lidocaine, and it was resulting in neurotoxicity. This transient neurological symptom can occur. Okay, and even any like hemodynamic sequelae can occur. So thing like that. There is no specific answer to this question. Okay, so if you give adrenaline instead of atropine, yes, what will you do? If you give adrenaline instead of atropine, what will happen actually? Who asked this question? Is he still there? Dr. Kabiro Harun? Actually, if you are giving atropine, in place of atropine, you give adrenaline, there will be severe tachycardia, severe vasoconstriction, there may be arrhythmias. Okay, so you have to treat accordingly. Like you can give some propofol, you can give whatever arrhythmias occurring, you can treat those arrhythmias, because it's not a its effect will finish.
Set pattern.
Sorry.
Yes, there is no set pattern of arrhythmia. Any arrhythmias
That
can
pattern of
occur.
arrhythmia, maybe it will be different in different patients. Okay. So, okay, sir, in case of broken needle, what is preceding criteria? Actually, again, you have to consult the place where it is broken. Okay. For example, if you broke in the spine, you will considering to have a, like, you can have an X-ray, you can have, you will have to consult with the surgeon, because you cannot cut and remove it. Okay. There will be involvement of.
Sir, if it's in epidural space or in spinal, in subarachnoid space, I think there are different approaches to both of these.
Epidural or spinal?
In epidural space or in subarachnoid space, you have to first think where it is in, either it is in epidural space or in the spinal subarachnoid space. Then you will decide what to do, urgent neurosurgical consultation or not.
Yes, it will be an individualized approach. Okay. But usually there will be some neurological problems. There may be some cardiovascular problem. Usually it will occur and you will deal accordingly. Okay. If you have injected any wrong medication, and because ultimately it will be absorbed in the blood. Okay. So whatever problem it will create, and then it will be absorbed. And another thing which I just recalled, I will take your question, Sadia, that there are another never event is that by mistake you manage to put the guide wire inside the vessel. It's possible.
Yes, sir. My junior trainee has done this during CVP.
Okay, so then that will be a nightmare. You will have to immediately call for vascular surgeons, and they will locate and remove it. Okay, because it can go anywhere. It may remain there, or it may go having a world tour. Okay, so guide wire. I will just give you a tip that whenever you are doing any procedure with Seldinger technique, what is my routine? I twist the guide wire at the end. Okay, I just make a twist so that the twisted guide wire cannot push inside. Okay, you just twist it at more than 90 degrees. So it will be twisted and it will make a hinge. So it cannot go inside. So this is my routine. Everyone has got his own routine, but it is a known complication or known never event which can occur. Okay. So Arif, I think I answered your question, and thanks all of you to join. And any questions, anytime you can drop a message on WhatsApp, and this related topics, which actually I have done this topic before as well, I suppose. Okay. Don't look at my list. And so my objective, actually the recording was not being done, so I will just start again few words, and then just a second. So you can see this playlist, and there you will find a list of this critical incidents.
It's not visible, sir.
I'm sorry. Thanks for reminding me, because otherwise I would have done like that. Okay. So these are some of the critical incidents I shared before. Okay. Actually, this should not be in the critical incidents, but I just put it as a shock. So otherwise, intraoperative arrhythmias I had discussed before. This is a question which is asked number of times, collapse and reduction. The earliest one will be in, actually, unfortunately, in Urdu, and the later one, all of them are in English. Okay. So I will highly suggest you to have a look at it, and you will learn a lot. Try to understand this basic hypoxia, hypercarbia, acidosis, tachycardia, bradycardia, hypertension, hypotension, arrhythmias. Okay. and how to deal them. Okay. So I think in this one, I had discussed this topic before, this never events here as before as well. Okay. So you can have a look on all the playlists, or if you want, and any questions, if you don't understand, all of you can just share the link of the video in which, and the minute, you can just tell that at this minute what we are talking, so I can explain. All the junior residents, I will highly suggest you to listen to this preoperative risk stratification and planning. Okay, because believe me that if you are able to understand how you plan a case, you will have no problem. The problem is that we don't understand how to plan, and we only say as pre-anesthesia assessment. It is not pre-anesthesia assessment. This is the whole anesthesia. This is the whole anesthesia which you do before starting. You plan everything. Okay. So anyways, thank you very much. We will meet again, inshallah. Okay, bye-bye.